opportunity to chair the session. And we have a very eminent speaker with our side, Dr. Anshul Jain sir, Head and Consultant, Interventional Cardiologist, Shri Aggarwal International Hospital. He has many publications and many intervention to his name. He's doing all the interventions type rota ablation and complex PTCAs, peripherals. So it's a pleasure to hear from him about the cardiac markers. Sir, please share your wisdom with us.
This topic is very close to my heart, and I've been working on biomarkers for last 8-10 years now. And the biomarkers, so for clinicians like us, the dictum is that we treat, he cures. And as we try to cure diseases which keep on boggling us left and right, it is he who gives us hope, and we are the ones who get our patients to be hopeful, not to lose hope, because probably we can do something good about them. And every time a clinician feels and a patient feels, he let somebody come and tell me what's going to happen. What is the disease? What is the outcome? How am I going to respond to the medications? So this perpetual dilemma continues both in the minds of doctor treating the patient as well as the patient. In this light, the biomarkers come to a rescue. So the biomarkers are naturally occurring molecules, genes, or certain characteristics which a particular pathological or physiological process, disease, etc., can be identified. They help in diagnosis, drug response, or drug target identification or prognostication. So just to say that in diagnosis, a particular biomarker may help to refute or establish a diagnosis. It can help us understand the underlying pathological process. It can help us to stratify the risk of a particular pathology, detect the severity of disease or any adverse consequences. It can be of immense help in therapeutic monitoring of a particular malady. So in cardiology, a plethora of biomarkers have been evaluated, actually in thousands. So the vascular medicine involves the vessel concern. So we are interested in the continuity and the physiological function of endothelium and the vessel. We are interested in the blood, the coagulation factors, the flow of the blood, the standard Virchow triad. So we see that many biomarkers have been evaluated in the subhead, as you can see here. The lipid-related matters, the markers of vascular function and humoral activity, renal function markers, metabolic markers, coagulation markers, angiogenesis markers, etc. But the commonly used biomarkers in cardiology are basically these few categories, of which we will discuss 3-4, which are used day in and out in practice, and they really help us a lot in treating the patients of various varieties. So the biomarkers of myocyte necrosis like troponin, biomarkers of hemodynamic stress like BNP, the acute phase reactants like fibrinogen and hs-CRP, biomarkers of coagulation like the dimer, and the latest and the recent biomarker of bleeding risk, the growth differentiation factor 15, which I am going to discuss in detail, because this appears to be changing the way we treat our patients with oral anticoagulants. So coming to the first one, the troponin. Whenever a patient with chest pain comes to us, the question is, are we dealing with acute coronary syndrome? I see about 10 to 15 patients a day with chest pain, of which only 2 or 3 or 4 actually have a pain which is related to heart or vessels. So the obvious question is, can I send him home, or do I need to admit him? If I have to admit him, do I need to rush him to cath lab? Or what is the prognosis of any patient with coronary artery, with acute coronary syndrome? So these are few questions which the troponins, they help us answer. So if we see the acute coronary syndromes, this is how the biomarkers are released in various pathological stages. So in a stable coronary, you can see myeloperoxidase, CRP, or interleukin 6, which basically represent the inflammation. When the plaque ruptures, the ECG may still be normal, but you can detect all these various inflammatory biomarkers. Once the thrombus sets in, then of course the fatty acid binding protein and the troponins are released when the myonecrosis sets in. So that is where we can detect, and this is the standard paradigm which shows the days and duration of the release of commonly used biomarkers, of which most of these, like myeloperoxidase, myoglobin, fatty acid binding proteins, they have been relegated to research more or less. Basically, we are left with troponins, which have stood the test of time in helping a clinician achieve diagnosis and helping us in treating the patients. So as we know that troponin is released because of muscle necrosis. There are three categories: T, troponin I, and troponin C. Of these, troponins T and I, they are reasonably stable and they are in blood circulation for sufficient period of time so that they can be detected and assayed accurately. And now we have high sensitivity troponin assays, which are now easily available. The normal value of troponin is 0.01 nanogram per milliliter. And these biomarkers are gold standard for actually establishing a diagnosis of myocardial infarction or ischemia. So when a patient comes to emergency, he has chest pain with a plus minus ECG, not very contributory ECG. What do? The idea is very simple. We do a high sensitivity troponin T or a troponin I. If the levels are less than 12 nanogram per liter, you can safely rule out that the patient does not have acute coronary syndrome. If the troponin T at 0 hour, that is at the hour of presentation, is more than 52, it is a definite diagnosis of acute coronary syndrome and the patient should be admitted. However, the intermediate values, the patient should be kept in observation for a few hours and the test should be repeated. After 1 hour, if the change of troponin is less than 3, then again you rule out. But if the change of troponin is more than 5, then you should admit the patient and the patient should be evaluated and treated as per the requirement. Intermediate ranges, the clinician's decision is final. If the clinician feels that he is high index of suspicion for coronary disease, the patient should still be admitted. Following this protocol, the ruled out patients, the patients whom we had sent home, they had only a 0.5% risk of METI within 30 days. So very safe and a very easy method of diagnosing whether the patient really needs to be in hospital or not. The same procedure, the point of care test, can be done when the patient is being transferred in ambulance. If the levels are more than 50, the cath lab can be advised to get ready so that the patient can be shifted directly to cath lab once the patient enters the emergency. Thereby, we can cut down the time, the golden hour time, and open the artery as soon as possible. So, to establish a diagnosis of non-QMI, the value should be more than 2, or in case of troponin T, more than 52 or 50, as per different things. The value of troponin T at the time of presentation actually predicts the all-cause mortality. So not only it helps in diagnosing, but it also helps in prognosticating the patient after the patient is being treated in the hospital. Next, we come to the second biomarker which is used commonly, which is the C-reactive protein, or more precisely the high sensitivity reacting protein. So the question in mind of cardiologists is, can some marker provide additional predictive information beyond traditional risk factors? Or should an asymptomatic individual with normal LDL take statins? So this biomarkers really comes to our rescue in answering these two questions. So CRP is the acute phase reactant, which is produced in liver in response to cytokine production. And the standard CRP test determine levels which are increased up to 1,000-fold. But the high sensitivity, they can detect samples even within the normal range. That is the advantage of doing high sensitivity CRPs. So to give you an example, that most of the individuals who come to us, they have either no risk factor or only one risk factor. So more than half of the patients who come to a cardiologist have only one risk factor, and two risk factors are present in about 90% of cases. So it may not be very easy to diagnose or to consider whether a patient has a chest pain or a problem of cardiac origin. So for example, we have a 40-year-old male with a borderline BMI. Normal is 25, here the BMI is 27, so borderline. He does not have any of the conventional risk factors, but has a strong family history of coronary artery disease. His LDL levels are marginally raised, and he had a negative treadmill test. But when you do an angiogram because of chest pain, he turns out to have triple vessel disease. So the question in mind of a cardiologist is, could I have done something else which could have warned me to evaluate this patient better instead of letting him get a myocardial infarction? So the question is, you could have done a high sensitivity CRP estimation. If the CRP is less than 1 milligram per liter, it is low risk for atherosclerosis. If it is less than it's less than 3, again it is moderate risk between 1 and 3, and 3 to 10 is high risk. So the index of suspicion in treating these patients should be very high. More than 10, it is considered as acute phase reactants, and we should ignore this view for cardiac evaluation, and we should look for infection or inflammation elsewhere in the body. So we see that risk factors for future cardiovascular events, a lot of them have been evaluated, but a combination of high sensitivity CRP and total cholesterol to HDL cholesterol ratio, that gives us a maximum prediction of occurrence of future cardiovascular events. So very important for us. We all doctors think our cholesterol is borderline. Should we all take statins or not? Well, the answer is very simple, which was seen in the FCAP study, that if you have a low LDL and low hs-CRP, administration of statins doesn't help. So you need not take medicines yourselves. However, if your LDL is low, but you have high sensitivity, your hs-CRP is high, then it is effective to take, it is reasonable to take statins to get your levels of LDL to less than 70. So clinical relevance, again we see that once you treat these patients, once the patient's LDL level is less than 70 and CRP is less than 2 milligrams per liter, you can see that the cumulative rate of recurrent myocardial infarction and death from coronary causes is reduced or is the least. Similarly, the C-reactive protein predicts short and long-term survivals after acute myocardial infarction. Another dilemma which a cardiologist faces day in and out is breathlessness. A patient comes to us with breathlessness. So the question is, does he have a cardiac cause of breathlessness or not? Should I label it as congestive heart failure or not? If yes, then what is the prognosis of this patient with congestive heart failure? So the evaluation of BNP's results, it really helps in diagnosing whether the patient has a cardiogenic source of breathlessness or not. It helps us to rule out COPDs especially. So 65-year-old female, known case of bronchial asthma, recurrent admissions due to dyspnea, borderline ejection fraction. Does she have cardiac contribution to dyspnea or not? You can just do a simple NT-proBNP test. If it is high, the patient could be having a contribution of cardiac factors, else it is pure bronchial asthma. So the NT-proBNP has number of benefits over BNP, which includes it has substantially longer half-life, higher circulating concentrations, both molar and mass, due to slower renal clearance, greater in vitro and in vivo stability, and lower vulnerability to circadian rhythm. So normally, these are the levels. One has to be very careful in interpreting these levels because they depend on age. So less than 50 years, 450 is the cutoff level. Whereas when somebody is between 50 to 75 years, it is 900 picograms per ml, which is the cutoff or rule out value. More than 75, it is 1800 picograms per ml, which is the cutoff value. So one has to interpret the levels of NT-proBNP in considering the age of the patient also. However, for all ages, if the NT-proBNP is less than 300 picogram per ml, it basically rules out any congestive heart failure. So these are the multiple reviews which suggest multiple trials which give multiple levels. They vary slightly from Europe and between different authorities, but more or less than 300 rules out congestive heart failure, and then 400, 950 and 1800 depending on what is the age of the patient. Now, when you interpret NT-proBNP levels, one has to be very careful that they may be lower than expected in patients who have obesity, pulmonary edema, pericarditis or genetic polymorphisms. Similarly, you may have higher than levels of NT-proBNP depending on the age, as I just marked out, patient with acute coronary syndromes, atrial fibrillation, renal insufficiency, right ventricular dysfunction, anemia, sepsis, or pulmonary edema or embolism. So you have to know the clinical condition of the patient before you interpret the NT-proBNP levels. So the NT-proBNP levels have actually been incorporated in the European guidelines for heart failure in the definition of heart failure, especially in the group where the diagnosis is not very clear. For example, in heart failure with medium range ejection fraction, where your symptoms and signs may be plus minus, ejection fraction varies between 40 to 49%. If you have elevated levels of natriuretic peptides, it helps in aiding the diagnosis of congestive heart failure. Similarly, in patients with heart failure with preserved ejection fraction, elevated natriuretic peptides in presence of symptoms or presence of LVH or left atrial hypertrophy points towards a diagnosis of congestive heart failure. The most important benefit of these BNP levels is actually the negative predictive value. If these levels are less than 300 for NT-proBNP or 100 picograms per ml of BNP, then it actually essentially rules out congestive heart failure. Similarly, in patients who are being treated for heart failure, if you follow the BNP levels serially, those patients whose pre-discharge levels are more than 700, they have maximum rates of death and readmissions, in contrast to the patients where you are able to achieve a level of less than 350 picograms per ml. Similarly, there is incremental benefit of natriuretic peptide testing in acute heart failure, as I just mentioned. In patients who have valvular heart disease, elevated BNP in patients who are class 2, basically borderline for surgery, elevated BNP means that you should have a higher and more aggressive approach in treating these patients, be it mitral regurgitation, be it aortic regurgitation, or be it aortic stenosis. So another biomarker for heart failure is ST2. As we know that this is a biomarker of myocardial fibrosis. So in a patient with chronic congestive heart failure, we are always thinking, what is the prognosis of this patient? What is the mortality? So ST2, as we know, it's a class of interleukin 33, and it is of two types, the ST2 ligand and the soluble ST2. In a normal heart, the soluble ST2 levels are less, whereas the ST2 ligands are available, so that whatever interleukin 33 is released, it binds to the ligand ST2 levels and results in cardioprotection, protecting the heart against myocardial fibrosis. Whereas in heart failure, when the interleukin 33 is produced, it gets hardly anything to bind to the ligand ST2. Most of it is taken by soluble ST2. Hence, your ST2 levels are high and it affords no cardioprotection. Thus, high levels of ST2 prognosticate a poor marker. As you can see, anything more than 0.35 nanogram per ml prognosticates a very poor prognosis, a high death rate in individuals with heart failure, where the ST2 levels are more than 0.35 nanograms per ml. As compared to galectin, ST2 quartiles are more predictable and more helpful in diagnosing and treating the patient and prognosticating the patients. Another gray area for cardiologists is the pulmonary embolism. The D-dimer levels, as we know, are commonly measured, especially now in COVID times also. So they are a marker of increased thrombolytic activity within the body. You see this example, it's an echocardiogram, not moving. So this is a thrombus in the right atrium, which is mobile. So occasionally it is very difficult to diagnose a patient with breathlessness in medical intensive care units, whether he has pulmonary embolism or not. In this case, a normal level of D-dimer, less than 250 nanograms per ml, has a high negative, 95% negative predictive value. And a negative diagnosis is very essential for cardiologists because it essentially rules out deep vein thrombosis or pulmonary embolism. Similarly, for risk stratification in the lower risk categories, if we see that In low risk categories of pulmonary embolism, where the echocardiography is essentially normal, if you have evidence of myocardial injuries in terms of elevated troponin I, it is essential to admit these patients and treat them more aggressively in hospital. You cannot discharge these patients. So again, in risk stratification in pulmonary embolism, troponin I is a useful marker. Now coming to this newer molecule, GDF-15, the growth differentiation factor 15, can some biomarker predict the risk of bleeding with oral anticoagulants? As you all know, it's a nightmare for a cardiologist or a physician who prescribes oral anticoagulants and a patient starts bleeding, or a patient who undergoes CA bypass surgery or angioplasty has a GI bleed. So you really want, can some biomarker predict the risk of bleeding with oral anticoagulants? So the growth differentiation factor 15 comes to our aid in this regard. I am told that the GDF-15 assays will be introduced sometime next year end in India by Roche. So it is a stress responsive member of TGF, that is the transforming growth factor cytokine superfamily. It is released and secreted in response to inflammation, oxidative stress, hypoxia, or telomere erosion, or oncogene activation. Cardiovascular disease is a major driver for GDF-15 production. It has favorable pre-analytic characteristics and can be measured in serum and plasma by immunoassays. In health, it is rarely expressed in human tissues, excepting the placenta, which means that in pregnancy, the levels are naturally high. Under pathological conditions, GDF-15 can be produced by many cardiovascular and non-cardiovascular cell types, and the elevated levels of GDF-15 are context dependent, and they may vary with the stage of disease. One has to be careful because even without disease, the GDF levels may be high in these conditions, extending from atrial fibrillation, pulmonary embolism, cancers, terminal illnesses, inflammation, higher age, smoking, etc. So the normal levels are less than 1200 picograms per ml. Moderately elevated is considered to be 1200 to 1800 ml, and highly elevated is more than 1800 ml picograms per ml. So a point to consider is that in community dwelling individuals, in normal individuals, GDF levels may increase. The levels of GDF, if they are found to be increased in asymptomatic community individuals, they are associated with increased risk of developing cardiovascular disease or renal disease and cancers. So that is the relevance of GDF-15. And it is independent of traditional cardiovascular risk factors, renal function, and other biomarkers. So for viscerous coronary artery disease, if the GDF-15 levels are elevated, they are a marker of future events and increase all-cause mortality. And they may help us select certain non-STEMI patients for early revascularization and invasive therapies. In cases of atrial fibrillation and heart failure, they portend a poorer prognosis and reflect a chronic disease burden and acute perturbations in heart failure. So in evaluation for cardiovascular biomarkers and analyzed rate of stroke or stroke embolism, so we see that high sensitivity troponin T, anti-proBNP, and GDF-15, they are independently associated with higher rates of stroke or systemic embolism. Whereas the troponin T and GDF-15 were both independently associated with higher rate of bleeding, but anti-proBNP was not associated. So the relevance based on this test or based on this analysis, a bleeding score has been developed, which is called as the ABC bleeding score, which is basically age, biomarkers, which includes the troponin, high sensitivity troponin T and the GDF-15, and C stands for the clinical condition, which means previous stroke, renal failure, and the anemia status. And we see that this turns out to be the ABC bleeding risk calculation, which is so simple. The moment we are going to have the GDF-15 analysis available to us in India, actually this will help us in prognosticating or identifying the patients who are at higher risk of bleeding. At the moment we are using this score called as hs-blood score, which is not very informative or not very helpful. So this is how the various biomarkers have been helping the clinicians in diagnosing, therapeutic monitoring, and prognosticating various maladies. So to conclude, the biomarker research has yielded several molecules which the clinicians are using to diagnose, prognosticate, and guide the therapy. Troponins, hs-CRP, BNP, D-dimer are already a part of standard cardiac treatment and management protocols world over. GDF-15 is going to be incorporated shortly in the ABC protocol and appears to be very promising in prediction of bleeding with oral anticoagulants. Development of various point of care assays has revolutionized the triage management protocols. However, the future lies in multi-marker approach. No single marker is going to help us or going to be so sure that this is going to be it. It's going to be a multi-marker approach, and unlikely that these markers will be used for risk stratification in isolation. Thank you.